Welcome, everyone, to the Center for Global Development. I'm Amanda Glassman, the Executive Vice President and a Senior Fellow. And today we're really pleased to have some new research presented here today from a team at the Jameel Institute, Imperial College London. Back in July, we hosted an event from a team of modelers at Metabiota and also from the Africa Risk Capacity group that were looking at what were pandemic risks going forward. Sure, this current situation has been incredible, but is it really a once in a generation event, or is it something that would happen more frequently? And at that time, those modelers shared their estimates that there was a 47 to 57% chance of another global pandemic at least as deadly as COVID-19 occurring in the next 25 years. And that there was a clear need, of course, to effectively prepare for future outbreak possibilities. But connected to that, we were doing some work here at the Center for Global Development in support of a high-level independent panel for pandemic preparedness and response. It was mainly economists and finance officials, and they were asking us, fine, but what is the return on investment to these? You're asking us to put up a lot of money now, and every year that comes, the potential benefits are not very visible if we don't have an outbreak of a pathogen that's potentially dangerous. But what is the return over the short and medium term? So we're really pleased that this team from Jameel Institute, Imperial College London, conducted extensive modeling work, and they brought together two pieces of the puzzle to look at both the benefits of the epidemiological benefits, but also the economic benefits from investing in prevention preparedness. They looked at deaths that would be averted and the effects on short-term GDP loss associated with potential future pandemics and of different pathogens, those a set of pathogens, because we also know that the next pandemic may not look like the one that we are experiencing now. So without further ado, I'll turn it over to the Imperial College London team. We're accompanied today by Katerina Hauk and Patrick Dewin. You have a number of collaborators as well that you'll tell us about, but I'll let you kick us off with the presentation. Then we'll turn to our discussants. We have Professor Sarangi and Dr. Anne Bucher from Bruegel, a think tank based in Europe. So over to you.
Thank you very much, Amanda and colleagues. It's such a pleasure to be invited here to present our work on pandemic preparedness, which you really instigated and helped us with. So I'm here joined socially distant by Patrick Dewin. He's a research associate and mathematical modeler who will present this together with me. And I'm Katerina Hauk. I'm a professor in health economics and deputy director of the Jameel Institute. Now, I want to emphasize that this is an absolute team project, and the individuals listed here on our slide have crucially contributed to this work. This is Alessandra Lochen, David Haw, Giovanni Focchini, and Peter Smith. And some of them are present today as well to answer all the tricky questions. So let me make a start. So what is the return on investment of pandemic preparedness? A really difficult question for us to answer. We know that the COVID-19 pandemic, as you said, Amanda, in your introduction, is associated with enormous costs, health costs, economic costs due to mitigation measures that reduce economic production, but also due to behavior change and interruption to supply chains. And not to forget the social costs that are related to the mitigation measures, the lost years of education for the next generation. So all enormous costs that we tried to value with our work. So what is the value of being prepared for the next pandemic once it occurs? It's first a reduction in direct, but also in indirect health costs related to the pandemic and displaced services for other diseases in terms of mortality and morbidity. It's also the reduced need for severe pandemic mitigation measures that need to be adopted once the emergency strikes. And then an associated reduction in economic and social costs. So our objective was to project with mathematical modeling some of these costs, not all of them, but at least some. And we used a model that we have developed for SARS-CoV-2, which we adapted to do this work, which is the data loss model. We analyze differences in costs related to pandemics, and these are between different countries, between different pathogens, and assuming different mitigation strategies that are adopted by countries potentially as the next pandemic strikes. And we estimate the reduction in these costs if countries were better prepared. So we're asking very hypothetical questions. And then we estimate the return on investment of specific pandemic preparedness measures. Now, as I said, the work is based on a mathematical model, which is an integrated epidemiological-economic model. The basic workings of the model I will try to explain now, but in summary, we assume that economic activity adds to both workplace and community-based disease transmission, but that the contribution that sectors make varies by the sector. And also the GVA or the GDP contribution that sectors make, so the contribution to economic welfare, varies by economic sector. The model is explained with all the mathematical equations on our website. So here I have the link that I'm happy to share as well with folks afterwards. The population is stratified in 4 groups. And for this work, we stratified the economy in 36 sectors. And we try to reflect the complex supply chains that are in place between these economic sectors in all countries. You can see a diagram of the SEIR model that we estimate the compartmental model for the different pathogens on the right side. And so the basic working of the model is similar, just for different pathogens, we have different parameters related to these, to the epidemiological characteristics of the pathogens. Now, importantly, the contact rates, which tell us how often one person meets another person that may result in the transmission of disease, these contact rates vary by age group and they also vary by economic sector. The disease transmission in our model is controlled through the closure of economic sectors, or rather the partial closure of economic sectors for production and then also associated for transmission. That reduces the health costs here in terms of deaths, but it also incurs a short-term economic loss, which we reflect in the loss of pre-pandemic GDP in the short term. Now, here a diagram of one country. So the economy is split up in the various sectors of the economy with employees. We also have the education sector there separately because it's a bit more complicated to determine the economic output of education. Workers travel between the community and the workplace, community on the right side, via public or private transport. And the community further interacts with the economic sector by consuming goods and services. Now, all of this leads to transmission of disease, and that is indicated here by the little viruses in the diagram. Now, the economic sectors all contribute to gross domestic product, the welfare, or simplified, the welfare of an economy in form of GVA, or gross value added. Now, the complicating factor is that sectors rely on intermediate inputs from other sectors in order to function properly and to produce the goods and services that they want to produce. So these are essential inputs. Here, for example, Sector 1 produces essential inputs for Sector 3, and then Sector 3 produces essential inputs for Sector 4, who then goes on to produce end products. Now, all sectors, of course, may also produce end products in addition. Now, variations in labor force. There are differences in the number of employees by economic sectors. So some economies are more heavy, for example, on agriculture. So then here, as an example, Sector 1 would have more employees than Sectors 2. So a policymaker may think, okay, Sector 1, which contributes more to transmission, there's more virus going on in Sector 1. So what do? We could close down this sector with these many workers and send them home into the community so that they sit at their desk at home and work from home. Then we have less transmission. Now, of course, what we also have is we have less GVA contribution here, symbolized by fewer coins coming from sector 1. So that's one way of looking at this. But then there are also sectors, and that makes it a bit more complicated, that might have the same number of employees, but they vary in the contract rates. So for example, sector 3 might be hotels and restaurants. So the hospitality sector, where there are a lot of contacts between workers and consumers, compared to another sector that might have the same number of employees, but fewer contacts going on, for example, financial services, which is mainly office-based work. So then a policymaker may think, oh, great, we will cut out and send home the workers from sector 3, which has so many contacts, and by doing that, reduce transmission dynamics. So that again will result in a reduction in transmission and less GVA contribution from that sector. So how do we do our impact projections? We first will project what happens when we send workers home with respect to transmission dynamics with a dynamic transmission model. So from day to day, we can say how that impacts on the trajectory of the pandemic. And we will also calculate how much less essential inputs are going from sector 1 to sector 2, and what is the hit to GDP from these two sectors. So that's what the model does. Okay, but of course now, when we had to apply this model to pandemic preparedness, there was much uncertainty surrounding the severity, government response, and the impact of future pandemics. So what we did, we assumed 4 countries and 4 potential pathogens, which are varying in transmissibility and severity, in order to reflect the whole spectrum of a future pandemic that may hit us. So these 2 parameters are pretty important. Then, and we look at 3 mitigation strategies, 6 pandemic preparedness measures, which we took from the WHO's National Action Planning for Health Security, or NAPS. And we tried to formulate how these 6 pandemic preparedness measures would change parameters in the Daedalus model. And then we estimated, our brave colleagues estimated over 500 pandemic trajectories in order to find out what our key projections are on return on investment. The output is the death toll and the short-term GDP loss over the duration of the pandemics. The costs of this pandemic preparedness over a 10-year planning period that we have adopted, ROI estimates for an unmitigated pandemic. So while we calculated other mitigation strategies, the ROI estimates are for an unmitigated one. And we monetize the years of life loss that are averted with pandemic preparedness and the short-term GDP gain. And we use methods of annuity to take into account uncertainty around the timing of the future pandemics. Now we have 4 countries that we focus on, which nearly comprise of half of the world population actually, which is USA, UK, China, and India, to reflect the different income levels. And we used a lot of data to parameterize our models. Population data, contact matrices from secondary literature, hospital capacity, which is important for formulation of our mitigation strategies. And then we took a lot of other parameters on pandemic response from the current COVID-19 pandemic, assuming that this would be replicated in future pandemics with respect to adherence to other non-pharmaceutical interventions, apart from economic closures, and with respect to what happens with the vaccine rollout. We have economic data in order to reflect the complex supply chains that exist in these economies. We take input-output tables from the OECD. And we take labor force data as well from that organization. We looked at what happened to gross value added during lockdowns in order to get an idea of the economic hit of a pandemic. We took work from home proportions for the different countries, also collected during COVID-19, and the cost of pandemic preparedness measures from the Georgetown IHR costing tool. The epidemiological parameters are informed by historic pandemics. So as I said, we have really two key epidemiological characteristics. First, the transmissibility as reflected by R0 from historic pandemics, and then hospitalization rates and fatality rates in order to understand severity. So these are CHR and CFR. And then we take various other parameters which are important to know, such as the length of the infectious periods and length of stay from the historic literature on these pandemics. And we focus on swine flu, Spanish flu, COVID, and SARS. And this actually, when you talk to epidemiologists, is the broad spectrum of transmissibility and severity that we might expect for any future pandemic that might hit us. I will now pass on to Patrick, who will take on my seat.
Thank you, Katharina. So in addition to the uncertainty surrounding the transmissibility and severity of the next potential pandemic, there's also uncertainty regarding the government response. What will they do exactly? And so different mitigation strategies must also be considered. The first of which is the unmitigated strategy. Here we are showing the epidemiological trajectory of an unmitigated strategy for a Spanish flu-like pandemic in India. And I would like to draw your attention to the pink line, which shows the hospital occupancy over time, and also to the dotted gray line, which shows the hospital capacity, which is held fixed. And in the unmitigated strategy, there is no economic lockdown imposed, but if the hospital occupancy, the pink line, exceeds the capacity, the gray line, then a higher case fatality rate will apply. There will be a change in behavior as individuals seek to avoid being infected, and this in turn incurs an economic hit. This strategy acts as an upper bound in terms of deaths, but a lower bound in terms of GDP loss. And this pandemic and all of the pandemics we consider are brought to an end through vaccination, which begins after 1 year inspired by the COVID pandemic, and the vaccination percentage of population is shown by the green line. The second mitigation strategy is the full lockdown strategy, in which lockdown is imposed as soon as the emergency is declared, and it is released at the conclusion of the vaccine rollout. This strategy is a very severe economically and will act as an upper bound on GDP loss, but on the other hand will be a lower bound on deaths. And so you could argue it would be suitable for the most severe pandemics. So here is an example of a full lockdown strategy imposed in response to a SARS-like pandemic in the USA. Finally, the third and most sophisticated strategy is the reactive closure strategy, in which lockdowns are triggered before hospital capacity is breached and released when occupancy falls to 30%. This strategy will provide intermediate deaths and GDP loss. And the example shows a reactive closure strategy implemented in response to a COVID-like pandemic in the UK. And the shaded regions are showing the periods of lockdown, and the white regions in between are then the periods in which the economy is reopened and transmission increases again. So how do we represent pandemic preparedness in the dataless model? We vary 6 different parameters relating to a number of P2 measures and NAFS categories. There is the government response time, the time at which social distancing and working from home orders are imposed. There is also the proportion of people self-isolating, which relates to the national lab system, real-time surveillance and reporting. Social distancing or adherence to NPIs incorporates face masks, shielding, travel restrictions, limits to social gatherings and other factors. Hospital capacity, which when exceeded a higher death rate applies. And finally, the vaccine administration rate, and the vaccine uptake, which relate to immunization and risk communications. Now on to our results. The first thing to point out is that current levels of pandemic preparedness vary drastically by country. Here I am showing the trajectories for a reactive closure strategy imposed in response to a SARS-like pandemic in the USA and in India. And I would like to draw attention to the vaccine administration rate and also to the hospital capacity, which is shown by the dotted gray line. And due to the difference in preparedness between the two countries, we see that only 2 lockdowns must be imposed in the US in response to the pandemic with the reactive closure strategy, whereas in India, 6 lockdowns are imposed due to the lower vaccine administration rate, which makes the pandemic last for longer, and also lower hospital capacity. And due to these 6 lockdowns, there is a massive economic hit to India, almost 18% of 2 years of GDP, compared to 5.7% in the US. However, the deaths are actually lower in India. This is because fewer people are allowed to get infected because of the lower hospital capacity. Also, demographic factors, which are incorporated in the model, will also play a role, since the average age in India is much lower than in the USA. We can study how the deaths and the GDP loss decrease with improved preparedness. As an example, we are going to look at a reactive closure strategy implemented in response to a COVID-like pandemic in China. And we are going to focus on 2 preparedness measures in particular, the vaccine administration rate and vaccine uptake. Each point on these graphs represents one particular pandemic trajectory. In the bottom left, we have the lowest level of preparedness, so low administration rate and low uptake. Whereas in the top right, we have the most prepared scenario with high administration rate and high uptake. The white circle shows the counterfactual, or our estimates for the current level of preparedness. And as we move from the bottom left, the least prepared, to the top right, the most prepared, we see that the death toll decreases and the GDP loss decreases. So moving from bottom left to top right. And each time we cross these jagged lines, it means we avoid 1 extra lockdown. To illustrate this, in the bottom left with the least prepared scenario, with low administration rate and low uptake, here is our pandemic trajectory. And we see that there are 5 lockdowns imposed under the reactive closure strategy when preparedness is lowest. This results in almost 200 deaths per 100,000 people and a GDP loss of 12.5% of 2 years of GDP. On the other hand, in the most prepared scenario in the top right, with highest administration rate and uptake, now only 3 lockdowns are required instead of 5. The death toll falls to 105, down from 200 per 100,000 people, and the GDP loss falls from 12.5% previously now to 8.9% of 2 years GDP. Showing that improved preparedness reduces both deaths and GDP loss. It's important to note that the most effective preparedness measures also depend on the pathogen. In the case of the Spanish flu-like pandemic, there is little waning immunity. And for the reactive closure strategy, shown here for the USA, there is sufficient natural immunity by the end of the pandemic such that vaccination has little effect. And so preparedness in terms of vaccine administration rate does little to reduce the deaths or the GDP loss. In this case, preparedness measures such as the government response time and the percentage of cases self-isolating are more important. The most effective preparedness measures also depend on the mitigation strategy. Here we have the example of an unmitigated strategy in response to a Spanish flu-like pandemic in the UK. If we focus on the death toll, we see that the percentage of cases self-isolating, shown on the y-axis, has a much larger effect on reducing the death toll than the government response time. So this is for the unmitigated strategy, so that the percentage of cases self-isolating is more important. However, if we were to consider a full lockdown strategy instead for the same pandemic in the UK and looking at the death toll, then with the full lockdown strategy, the government response time is more important than the percentage of cases self-isolating. Because if we're looking at the figure, we move from red to green quicker by moving from, by increasing the government response speed up. So the take-home message is that we can't tell which preparedness measures will be most effective in advance, and this is something that policymakers should take into account. This table summarizes the deaths averted as we move from the lowest level of preparedness to the highest level of preparedness under the unmitigated strategy for each pathogen and each country. For the very mild swine flu pandemic, there are no deaths averted, but for the more severe COVID and SARS-like pandemics, then the deaths averted are much higher and can be as high as 200 to 350 for COVID-like pandemic in particular. It also depends, or the deaths averted also depends on the country as well, which is reflecting the underlying demography. So again, for China and India, which have younger populations, the deaths averted with preparedness will be lower. Finally, we examine the return on investment of pandemic preparedness. Here we are looking at the deaths averted per $1 million spent on preparedness measures. And our underlying assumptions are that one pandemic will occur every 10 years on average, and the probability of a pandemic occurring follows a Bernoulli distribution, which then allows us to calculate the expected present values of GDP loss and P2 costs. So in the figure, we are showing the deaths averted per $1 million spent for our different countries and for a selection of pathogens. Again, we are seeing variation across both pathogens and countries, where most deaths are averted for severe pathogens, so for COVID in particular, and can be as high as 450 to 650 deaths averted per $1 million spent. And fewer deaths are averted per cost in our lower income countries due to, again, the underlying demography and also higher pandemic preparedness infrastructural costs. So we see that the deaths averted per cost are lower for India in particular. We can also examine the return on investment using a value of statistical life methodology, in which we calculate the value of years of life lost in each scenario. We then calculate the return on investment using the VYLL, the value of years of life lost averted, in moving from the least to the most prepared case, again for an unmitigated pandemic. And this is then divided by the expected present value of our P2 costs. We see that there is similar variation between countries and pathogens in terms of the return on investment in terms of VYLL. And it can be as high as $1,700 for COVID in the US. And we have the highest return on investment for the most severe pathogens again. We can also calculate the economic return on investment in terms of the GDP loss averted for each country and for each pathogen. Again, there is similar variation in the return on investment between countries and pathogens. But we see that the order of magnitude of the two is actually the same. So of the order of 1,000 return on investment per dollar invested in pandemic preparedness. This table shows the net economic benefits of pandemic preparedness, which is defined as the GDP loss averted through pandemic preparedness, less the costs of preparedness. And then this is expressed as a percentage of national GDP for our 4 candidate countries. For milder pandemics, the net benefits are of the order of 0.2% of GDP for higher income countries, but it is actually negative for India because the costs of preparedness in this case are exceed the GDP loss averted when there is a higher level of preparedness for the swine flu pandemic anyway. But for severe pandemics, the net benefits can be as high as 12% of GDP, again, under the assumptions of a pandemic every 10 years on average. But it is important to point out that these results are for the unmitigated strategy. And so these are likely to be a lower bound on the range of potential values if other strategies were to be considered. In conclusion, there is a large variation in return on investment of pandemic preparedness, which critically depends on the pathogen, the country, and the mitigation strategy that is pursued. If we were to examine the return on investment of pandemic preparedness in terms of VYLL averted, so the value of years of life lost, per dollar spent, or averted per dollar spent on P2, then the return on investment can be in the range of $34 to $1,703 for a severe COVID-like pandemic, $42 to $968 for a SARS-like pandemic, and from $4 to $415 for a Spanish flu-like pandemic. So the more severe the pandemic, the higher the return on investment. The return on investment is usually lowest for India because of demographic factors and higher P2 costs, and highest then for the USA. And the net benefits of pandemic preparedness in terms of GDP loss averted, so the economic benefits, ranges from 0 to 12% of GDP. Of course, there are a number of limitations to our analysis. The high degree of unquantifiable uncertainty makes the analysis speculative. And we also are making a number of simplifying assumptions in relation to migration and travel. We don't account for the emergence of variants. We don't account for indirect deaths. Our economic model is static, not dynamic, and many more assumptions. So thank you very much for your attention, and we will gladly answer any questions that you may have.
Thank you very much, Patrick and Katerina. You know, there's, of course, a million questions that will come up for anyone reading the paper or hearing your presentation. And you know, of course, the other piece is that we're looking at return on investment on in specific countries, right? Which is another, you know, we're not looking at the overall globe picture, which would be sort of a next phase. But I think one really important feature is that, you know, the net benefits for countries that may be lower middle income are lower, and yet the benefits are so high for high income countries, and yet what happens in the high income country is utterly informed by what happens in low and middle income countries. So I hope that we'll think about that as we consider, you know, what is the role for organizations like the World Bank, or that are meeting this week in their fall meetings, or high income countries in terms of financing what happens in low and middle income countries on preparedness. But before we turn to some of these thorny questions, I'm going to ask Professor Sarangi to come in and give us your views on this piece of work. You're obviously very deep in cost effectiveness research as well. And I know that you've been working on COVID-19 in India. So maybe you could kick us off, and then we'll go to Un.
Thank you, Amanda, and thank you, Katerina and Patrick, for this wonderful presentation. It's a lot to take in. I'm a modeler myself, as Amanda said, so I can appreciate the the extent of effort that has gone in. No model is devoid of assumptions, especially a large one such as yours. I'm sure you've tried your best, and then at some point we have to say we have no data, and so we have to make assumptions. So fully appreciate that. Thank you. I have a few thoughts, and I'm sure there are some responses, but I'll just open the discussion as Amanda said. I think the one point you mentioned this, Patrick, towards the end is the probabilistic structure of the emergence of a pandemic itself, right? I think you built it up very nicely with all the complexities, but the Bernoulli assumption about the emergence of the pandemic, if I got it correctly, right? That I don't know what's a better way to base your probabilities on. There's very little data. But what I was also curious about is the ROI was calculated conditional on a certain pathogen emerging. If it's SARS-like, if it is COVID-like, if it is swine flu-like. But when governments are preparing, they are not preparing in this conditional manner, right? So if there is a way to roll in the probability of which pathogen it will be that will emerge. So we, at the end of the day, want an unconditional ROI, something to think about. And like I said, I completely understand the difficulties facing that kind of an endeavor. So that's one comment. The other piece, which may be important, again, I'm thinking from Indian perspective, is distributional impacts. So GDP is an aggregate measure, and as a country, sure, we care about it. But what has also come through so clearly due to the COVID pandemic is it accentuates the existing fault line. So people who are vulnerable are affected far more than people who are not vulnerable. Those who are not vulnerable may develop coping strategies, or they may be in sectors. And so if your results already has those details to play them out and say how much is the inequity increasing, it's not just about aggregate GDP. I think that will be helpful. You probably, to last point, big point, and then I'll hand over. You again may have mentioned this about the dynamic versus static model. I was wondering if it also meant a response of economic players, right? So it's not just about exogenous dynamic behavior over time, but so for example, in India, we have a large IT sector. And the moment the pandemic started, firms responded to that by creating work from home approaches and strategies. That may be again differential across different sectors that have different kinds of work and different kinds of investments, private investments. And I wonder if that has been incorporated in the model. It wasn't clear to me. So I'll pause there, and thank you again for sharing your results. These are initial thoughts, and I'm happy to discuss more. Thank you.
Thank you, Sarangi. Really great points. And this model in itself is really incredible, because it's really, we have not succeeded at combining sort of the epi and health pieces of response with some of the economic outcomes. And I bet we all wish that we had that at the start of this pandemic. But the other thing is that they have to build in the different scenarios, which have limited data to build them. So, and then that's why also you can only do it for a couple of countries at the moment. But I think the illustrative findings are quite interesting. But you're raising some really important points, especially the one about sort of the distributional consequences. So I think we'll come back to that when we go back to you, Patrick and Katrina. Now over to you. You were my colleague in serving the high-level independent panel for pandemic preparedness and response. And this question about return on investment was there from day one. So we're really so grateful to the ICL team for making this attempt. And it is so complex. But it is, I think the results are quite clear actually in terms of what it means to engage in pandemic preparedness and what could be the returns to that investment. But I'll turn to you, An, for your reflections on the policy implications from this work.
I think, Amanda, you're right. I mean, this type of research is really needed to feed the policy debates, and I can only thank and congratulate the team for a huge, hugely complex exercise, which gives a lot of insight. And in fact, I mean, I was reading the document and I thought, okay, it's good because it provides us with return on investment, which we have seldom had. But it's also very interesting as a reading, and I really invite the audience to get into the details of the document on all the drivers of the results, because you get back to all these discussions which we have had over the last 2 years of what is the optimal strategy between elimination, suppression, and non-mitigation, yeah, and you start understanding the difficulty of the trade-off GDP, economic cost, health cost. So it has a huge potential, and I think, I mean, it's a very innovative, inspiring work, which is really useful, demanded by the policymakers. Yeah. I mean, I have a lot of questions, and Amanda said probably there's no time to go through all the questions, but let me maybe cluster my comments around 2 issues. The first one is, how could we validate? Now we have return on investment estimates. How can we validate this? What kind of reality test can we have? And the second is on the limitations. On the first one, on the validation, I mean, as you said, you now give orders of magnitude for return on investment for a number of countries and pathogens. They are fairly high. I mean, if you look at COVID, it is between 34 and 1,700 for the US. And then you ask yourself, how robust is this? Because the model is always a bit of a black box for even for those who build it. And I was thinking, you know, there was this work by Fan and Jamison and Summers who calculated the inclusive cost of pandemic flu. And they do not go as far as computing ROI, but they estimate expected annual losses. And they get, afterwards, they compare these losses with other areas. For instance, they come out with a figure of 750,000 expected death from pandemic flu, and they compare it to cancer, which is about 10 times that figure. And I think it's interesting, this type of approach, because we've all been struggling with the failure of collective action in the area of prevention and preparedness. I mean, we have the case for investment. The returns are high and you confirm it. And at the end, the area remains underfunded. And you mentioned there are different reasons why it is so. And one of the reasons is of course, opportunity cost. And when you compare, for instance, cancer to outbreaks with new pathogens, then, I mean, you get a bit of this feeling of what is the opportunity cost for governments who have limited resources and huge challenges ahead. Yeah, they also compare it to data on climate change, showing that at the end, the threat of pandemics is in the same order of the low bound of climate change. Yeah, so it's interesting to go in this direction. And I was wondering whether sensitivity test in your model, or whether comparisons with ROI calculation in other area would help to validate the results. And if you have some ideas on this. I have also, as I said, the second set of comments, which are more about the limitations maybe of the model. You're very transparent on the limitations. You said, okay, it's very exploratory and experimental, what we have now, and it's great. But when I was reading the model, I had lots of questions, and maybe I focused on 3. I mean, one is very close to what Sarang has. I mean, 2 are very close to what Sarang say. I mean, one is, at the end in your model, you estimate the return on investment on preparedness, but not really on prevention, because the model does not allow for the reduced likelihood of pandemics. And so maybe it's a lower bound which of the return on investment which you have. And I was wondering whether you have thought what it would take you to endogenize your likelihood of pandemics, and if it's one area where you're thinking. The second one is also the point that Sarang made, that at the end you calculate return on investment on specific pandemic when they occur, But in practice, a return on investment is an ex-ante variable to help the decision. And in the model, you make this average of the ROIs over the 4 pathogens. And I think that's the closest, maybe that's the relevant variable for the policymakers, what you think of this, because in your model, all the pathogens have the same likelihood of emergence, yeah? And my third point is really also another question to you, is on the scenario of outbreaks. You assume that the vaccine is available 1 year into the pandemic. And for COVID, we've been told that we were very lucky to have a vaccine developed within less than a year. And we can see that this influences a lot your results, in particular for the lockdowns. And so I was wondering to what extent, I mean, this is fairly optimistic. If you would change that assumption, you would get to return on investment even higher, I expect. And I was wondering whether you tested your model for different dates of availability of the vaccines. Would be very interesting to know. But I mean, okay, so that's, I selected my questions here, but I have many more, and I just wanted again to thank you and to congratulate you, because it's really it's a very interesting reading. I mean, I invite everybody to get into that paper. It's really exciting. Thank you.
Great points from both of you. Just a reminder to the audience, if you have questions or comments, please submit them at CGDev on the Twitter stream, or you can do it below the YouTube stream. So let's go back to you, Katerina and Patrick, to respond a bit to the points that have been raised, and maybe also invite you to reflect on what is the policy implication or the financing implication for the differential ROIs in lower middle income countries versus high income countries? What would it mean in terms of a more rational allocation of international financing?
Yes, thank you, Amanda, and thank you, Sarang and Anne, for your insightful comments. I mean, I really agree with all the points that you make there. I think a key question is this, the risk of a zoonotic outbreak occurring. So I think I refer that to David Haw, who is also on our stream and our senior epidemiologist, to answer that. So while he prepares his answer, I will think a bit. I think, Sarang, you made a very interesting comment on the distributional impact and GDP as a summary measure. I think what becomes clear now from COVID, also as we approaching recovery, we see what an incredible unequitable impact the pandemic had. And that is not only with respect to GDP as a measure, but also with respect to the social cost. We have countries such as Indonesia, which haven't seen on-site schooling for a year. This will have consequences that will far outlast the short-term economic losses that we are calculating with this model. So I think that is a major weakness in our model, that we do not have the distributional impacts in there, and that we do not place a value on these social costs and the long-term educational impacts. So I think if we were to consider that, the ROI would be even higher than we have at the moment. Then we do consider the response of economic actors, which kicks in during the overflow period. So basically in the period under the unmitigated strategy, when hospitals are overflowing, we assume a higher mortality rate first, because people don't get a life-saving treatment, but we also assume a reduction in economic output. So we model that super simplified as just a simple multiplier, but really it incorporates demand and supply side effects. So it incorporates the fact that people, to avoid infection, will reduce demand for goods and services. It incorporates the interruption to supply chains. It incorporates that people, particularly in low and middle income countries, need to look after their sick relatives, and if they can halfway afford it, will not appear at workplace anymore. So we have a super simplified way of modeling this, and I think in future iterations we would like to improve that. But I think that has to do with the short-term nature of our, and the static nature of our economic model, which I think is a clear limitation. So then, yeah, with respect to the unconditional ROI, we have attempted that. We were a bit at unease of doing this to average ROIs across pathogens, but that was the only crude kind of way we could see of doing that. So I think I pass now on to David to answer the question how we incorporated the risk of emergence of a new pathogen. And then afterwards, I will pass on to Patrick to answer some of the more modeling questions.
Hi, Katerina, thank you. I'm not sure I have very much to say on how did we incorporate the emergence of a new pathogen. It's been a sticking point across the whole discussion that we've had, because there is a non-quantifiable kind of uncertainty about what the next pandemic will be. I think we stuck with an idea of, we assumed there'd be one every 10 years, or on average, a pandemic every 10 years. And that came just from looking at the history of pandemics and outbreaks. And there was no intense calculation involved there. It was merely the observation that roughly one year in 10 something happens. So please don't read too much into that assumption. It was mainly a way of getting some numbers so that we could proceed with some kind of calculation. And I have one thing to add on your discussion regarding the long-term change of economy due to a pandemic. And this is something that our model does allow for. It absolutely does, but you have to be able to monitor the changes that have happened. So what we're not doing is forecasting how the economy changes as the result of a pandemic, but what we can do during a pandemic, in fact, what we are doing with the current pandemic, is monitoring changes in the economy, changes in the input-output, changes in the baseline of sector opening, and recalibrating our model accordingly. So it is something absolutely possible to be done in real time, but almost as difficult in advance of any pandemic happening at all to forecast. I hope that gives a bit more insight from me. Is there anything else you want me to comment on at the moment, Katerina?
Oh, that's fine. I think we pass on to Patrick to
Thank you.
walk up.
Yeah, so I guess a few points I'd like to touch on regarding the unconditional return on investment. It's like we did briefly consider and try to explore how we would go about doing this, but the issue is that we don't know what probability distributions, we don't like different pathogens or different pandemics will have. We don't know means or expected values. We don't know what parameter ranges. And so after some discussion, we pretty quickly gave up on that idea, and we decided to focus on just specific examples of pandemics that have occurred in the past to give us an idea of the range of possible values of returns on investment, both on the health side and on the economic side, just to give us a bound as to where the unconditional return on investment, like the range that this may lie in. Also, I would like to touch on one of the points that Anne raised about the timing of vaccination after 1 year, which we did assume was constant throughout all pathogens. And this is also something we discussed as to how the timing of the vaccine rollout related to preparedness. And we felt that on one side, there is a certain amount of preparedness that you can do to speed up the vaccine rollout. Say you could have, I guess, the regulatory systems and frameworks there to possibly have a faster approval of vaccines and the infrastructure to distribute vaccines and like give it to the, like roll it out to the population quickly. But on the other side, there's also a part of this process that is, I guess, more on the pharmaceutical side that cannot be influenced as easily. And it is something we have explored in the past as to like the timing of the vaccine rollout has just such a massive effect on the economic losses and the health costs that do occur. And it is something we can explore. Like in this analysis we did leave it out as a parameter, but it is something we could consider in future. I guess, again, like there is just the uncertainty as to what range of, like how much speed up can occur from improved preparedness is just the true unknown that we are grappling with.
Thanks. I mean, yeah, I mean, this sort of, I think 1 year in 10 is what the historical data suggests in terms of pandemic potential pathogens, but and we had this earlier group that sort of looked at a long-term historical data set that they had put together, but it's fraught with uncertainty. I think the term that David used is right, non-quantifiable uncertainty on what is the nature of pandemic risk, which is one reason why it's important to study pandemic risk more carefully if we can't really predict what's with any decency, sort of what's happening next or what's ahead. It's quite important. And so, and I think, the point that you've also made about GDP as a summary measure being inadequate and that there are all these other social costs, so it really does suggest that this is a lower bound, so quite important. But one topic that you didn't mention, Katrina, was around the sort of implications, given that there are these opportunity costs in lower middle income countries, but the net benefits are different. What do you, can you sort of draw a next step, which is what does that mean for policy? And the use of international financing. Can I push you to say what your view is on that?
Yes, I mean, what we observed was first that, of course, due to the age distribution or the age skewness of the case fatality rate and also the severity of disease of 3 of the 4 pathogens we looked at, the deaths overall were lower. So that is specific to the pathogens that we studied. Also, we realized that the Georgetown costings for pandemic preparedness were higher in India and in China. Now, we did not really find a reason why that is the case. So I think that is a further need to look into that. Because clearly that the cost of pandemic preparedness will impact on the return on investment calculation then in the end. I mean, in a way, looking at country level is understating the fact that we are living in a globalized world, and is a country level analysis at all appropriate to do, where a pathogen can travel within 24 hours all around the globe. And data limitations, of course, mean that we have to at the moment stick with the country level analysis, and national accounts on which our economic data are based are at the end of the day calculated per country. But I think very important it will be in future periods to extend this to incorporate international trade and migration of pathogens across borders. And then I think we will arrive to averaged ROIs that might look completely different again, and will call for international cooperation on pandemic preparedness as we see it for the environmental crisis.
One question that's just come in, and I know you have a slide on this, but just remind people, what are those preparedness investments that you're looking at when we talk about pandemic preparedness and it's labeled PP2, PP1, what's in that bucket of things?
Yes, so I think we need to remind do we have the table again?
Yeah.
So these are the NAPS categories from WHO.
That's the National Action Plan for
Health Security, I think.
Yeah.
Yes. So so they relate to the physical infrastructure, which are laboratory capacity, disease surveillance. We see now how important it is to have genomic surveillance in the case of COVID with the variants occurring. So that is one which directly then translates. We have tried to translate that into parameters in the data loss model, which is not straightforward to do, obviously. And then of course we have the whole medical workforce issues, which increase the capacity of the healthcare system to respond and treat cases that require life-saving treatments. But I think the main problem, I mean, what we found also during COVID, how important governance is and risk communication. Now, how on earth are we translating that into a mathematical model? So we have tried to translate that into government response time so that lockdowns are implemented earlier. Now, research of our colleagues here in the department has shown that even 1 week earlier lockdown prevents tens of thousands of deaths. So I think this idea of that acting early, I think with pandemic mitigation, I think is really, really crucial. And we have learned that during COVID. So I think the pandemic preparedness that allows countries to react early and to have the governance structures and to have the pandemic plans in place so that that we can react early. I think that is really important, and our model has shown how important that is for the mitigation strategies that we are assuming. And I think what's interesting then with respect to the vaccine side of things, yes, vaccines reduce the length of a lockdown if a country imposes lockdowns, but for unmitigated pandemics, it might come far too late, and for certain pathogens. Do you have something to add, maybe, Patrick, on this?
On the vaccine side in particular, yeah. I guess, yeah, it's the fact that different preparedness measures will have more or less of an impact, and this just depends so critically on the mitigation strategy and on the pathogen that it's just uncertainty upon uncertainty.
The difficulties of modeling. But just to say, I mean, on this list of measures for preparedness is not the research and development investments that would be required to get vaccines ready quickly, correct? I mean, the manufacturing investments and things like that. This was something that An and colleagues who worked on the panel tried to dive deeper into. That, of course, you know, one country's investment in that part actually serves the entire world. So it really is a global public good. But it would be great if all the countries would contribute to financing that as well, so that it's the costs not incurred by a single nation. Let me ask a couple more countries, and then I'm going to go back to the discussants to react to what you've heard. These are from one is sort of when life years are lost are valued by willingness to pay in each country. What do you assume to be the relationship between GDP per capita and the willingness to pay for a year of life? This is the whole value of statistical life problems versus willingness to pay, et cetera, et cetera, et cetera. Not an easy question. And then another question around, should policymakers consider their investments in pandemic preparedness as a portfolio? Like you've listed out some of the interventions, or is it that we want to choose some optimal portfolio of investments? I think we're so far from being able to answer that question, but maybe I'll turn it back to you for an initial response. I don't know, Sarangi, if you have thoughts on that before I go back to Katrina and Patrick.
No, I mean, yeah, there's a bunch of factors which are very hard to model. I was thinking similarly about the portfolio, but I think the more granular you get in terms of what's the return on this component of the portfolio versus that component, the assumptions just pile up, I think. So I again understand the approach that the authors have taken. this made me also think that when we consider policymakers, I mean, there are actual decision makers, right? And we know from behavioral decision theory under uncertainty that people don't go by expected values. Again, right? That's something I want to bring up. There may be, so again, it's hard, but what broad aspects of political economy could be factored in decision making, especially because these are once large consequence events, but rare. And so the thought process in politicians may not switch to calculate expected value, multiply probabilities by consequences. So are there other rules that one could use? I was just following the discussion in this effort.
More hard challenges posed back to the team. Do you have thoughts on the questions posed or what you've heard?
Yes, so maybe on VSL, I can quickly say that we had a very long discussion with Lisa Robinson, of course, our guru on VSL. So maybe Patrick, you want to summarize what in the end we decided on that?
Yeah, so we decided to go with the years of life lost approach, and where the value of statistical life was calculated and calculated using two methods based on either 100 or 160 times the GNI per capita at purchasing power parity. So these had to be sourced for each country. And then the two methods, the 100 and 160 factors, in a way determine lower or upper bounds that we were showing on our figures to calculate the value of statistical life in each country. And then this, we can then calculate a value of a statistical life year using the average remaining life expectancy in each country, which then goes into our calculation for the VYLL, the value of years of life lost. So a lot of alliteration here.
Yes, and the elasticity of one, we have assumed.
Yeah, I do commend people to look at this project that Lisa Robinson at Harvard School of Public Health had been leading, that looks at how to calculate cost benefit and the use of pros and cons of some of these measures and the assumptions that lie behind them. Of course, I don't want to say this, not normal people may not wish to give a monetary value to a human life. That is a frequent comment, which is totally valid. But when you're working with a bunch of finance ministers, they do sort of want to know what is the GDP impact of these things. So thank you for doing it. And it also helps us to contrast, as Anne was suggesting, how an investment in this space compares to other investments that might be outside of the health sector, right? Which is the point, right? If we're underfinancing health because of and we frequently use return on investment calculations in other sectors, whether it's climate or infrastructure or whatever. So we do have to contrast these things and make some assumptions. Obviously, we can change those things. That's part of what building a model is all about, that you can adjust some of the parameters that go into those models. I want to go back to Anne, but I have just to announce, I have another question about your results on China for a COVID type virus, because I feel like we're living that situation now, right? So they're doing zero COVID, they're doing lockdown, and their vaccination rates are increasing quite slowly. And so in a way, your model results are quite important today. So maybe I'll ask you to go back, just because this is not just about future risks, but about the continuing response to COVID. But go ahead, Anne.
I was, still thinking along the lines on the opportunity cost, and Sarangi is right that in life, policymakers do not decide on expected values. Still, when they look at the investment, they decide on the basis of whether that investment is useful for other purposes. Yeah? And in the area of prevention and preparedness, there's a whole series of things which is strengthening the health systems in general, which is useful. And maybe, the team has some ideas on the way some of the investment they look at, or investment which would help public health in general, like for instance, risk communication. If you have it for pandemics, you might have it for tobacco as well, or alcohol, and probably also on countermeasures or your lab systems, and so there might be a way of convincing the authorities in the low and middle income countries to go ahead, because it is an investment which they need to do for their health systems anyhow.
I mean, just to put in perspective, this is an area that's incredibly underfunded in low middle income countries. We actually don't know how much is currently spent on this from public monies. There's lots of disagreement about aid and how health aid is classified for this use, but it's not, it depends on what An was just saying. Maybe if my surveillance system works for existing infectious threats and it also works for emerging pathogens, I could classify, my spending on the surveillance and lab part of HIV/AIDS as preparedness, but it's not much of the portfolio. It's definitely less than 20-30% of the total aid portfolio. And then even in OECD countries, we spend on everything classified as public health and preparedness, less than 2% of total public spending on health. So it gives you a sense of the relative under prioritization of spend on this use. And also, I think, you're also this kind of portfolio versus specific interventions. It would make sense to try and test what are the most cost-effective ways to run genomic surveillance, to build lab capacity to run labs, to scale up civil registration vital statistics systems. And I think it's definitely an area that is under evaluated as well. For the obvious reasons that we don't spend anything on it. But it's quite important, as we can see from an economic perspective. So can I ask you about China and today, because they are facing a COVID type pathogen. They are kind of in a lockdown mode that is significant. If any thoughts on that?
Yeah, so here I think is our ideal. This is the fully prepared. So if they were fully prepared, or would have been, I think what does our model predict, Patrick? It says 3 lockdowns, right? 3 lockdowns and the GDP loss of 8.9 over 2 years and 104 deaths per 100K. So how would be the case for not prepared?
So on the previous slide. Well, first thing I would point out, this was for a reactive closure strategy, this particular result here. One thing that we don't consider for is when a country may decide or may switch mitigation strategy midway through a pandemic because of different factors. For example, the emergence of a new variant may render a containment or an eradication strategy ineffective, which is what we are seeing in certain countries. And so at this point, a country may decide, okay, we have been following one strategy up until this point and then having to change strategies. So this, in this case, and just this particular example, I would like to point out that it is reactive closure strategy from beginning to end. We are not accounting for changing of strategies midway. And just focusing on the vaccine-related preparedness measures, so the administration rate and uptake, we see lower bound, the deaths are in the range of 200 per 100,000 people. And then for the most prepared scenario, maybe about 100 deaths per 100,000 people. So I guess you could say that in following a reactive closure strategy, that we might be somewhere in between the two at the moment, and GDP loss then somewhere between 12.5% and 8.9% in that's a percentage of 2 years of GDP. So possibly somewhere in that kind of range.
With huge caveats, obviously.
Yeah. I think, one thing to reflect on, this is really the start of a new science, trying to put these factors together and to use what we've observed in the past to try and say something more about, how effective policies can be in the future. But I think, one of the main insights is just the trade-off between, or actually that there's no trade-off really, that better preparedness helps with both health and GDP. So that's useful. Maybe An, I'm going to go back to you and think back to the many meetings that we observed in terms of, what what to ask and to the international community, both about sort of the future of the science of studying pandemic risk and what it means to be prepared, the effectiveness of preparedness, as well as sort of what it means for the global financing discussion. Can you share a little bit about that work that we've been doing and what you see as next steps?
I mean, it would be very interesting to incorporate these results in what we have been starting for the G20 high-level independent panel. Yeah, I mean, I think, I mean, one of the big difference with what we have been talking about now is the fact that we have taken a global perspective instead of a country perspective, and we have. So we have defined, I mean, what we call the global public goods, and with the three categories of surveillance, strengthening of the health systems in the low and middle income countries, and then what is the global research, development, and production of vaccine therapeutics and tests, and I think, I mean, to some extent, it implicitly incorporates some of these results here, because here we are looking at the strengthening of the health systems at national level. And it's true that what we're saying in the report is that the research and development of vaccine is something which should be really global and not so much enshrined in national policies. And the way it is that probably high-income countries would take over that work more than low and middle-income countries, and would deliver a genuinely public good, what we call in the jargon of the public goods, the best shot public good compared to health systems strengthening, which are necessary that each country does it because the country is as safe as its weakest link. What we have been doing on the basis of these categories is to try to estimate the needs, and we have not started new data collection. We have basically looked at what's available, what's updated, what's realistic, what's the experience of the with the accelerator. What does the WHO already does in terms of surveillance, and on that basis we have come up with a figure which is that the world would need to invest in global public goods in the order of 15 billion a year, in addition to what is being done at national level. And that splits more or less equally between the three types of expenditures I have mentioned. I mean, surveillance, health systems, and developments of vaccine and therapeutics and diagnostics. So on that basis, I mean, we really push for a pooling of funds at global level. And I mean, I find that the calculations which are there, and the point that you made on Amanda, on the fact that high-income countries have a higher return on investment, justify that solidarity and the implications for high-income countries, that they put more in the basket. And I think we should use that argument to say now the developed world should really put in place a global prevention and preparedness system. And I think that the work which has been done by the team helps us in really putting the responsibility on the shoulders of high-income countries, because they have a high stake in this. And they have the capacity to also scientifically and technically put in place some of these measures.
I mean, I think that's put very well. And I think, but that said, there's a number of epidemic potential pathogens, I think, that are localized in low and middle income countries alone, that are not amongst the four that you've looked at necessarily. And these are, some of these other threats that we were talking about. And so I guess a question to maybe I'll put you on the spot, Sarangi. Can you reflect a little bit on that? Because, okay, well, it might not be that cost effective for India to do a lot of investment against some of these, well, maybe I actually think that the case is still there for, swine flu, let's say, but we could talk about that. But, Nipah is something that has emerged in India and had huge consequences. likewise, there are other kinds of pathogens that are specific to sub-Saharan Africa. So maybe I'll ask someone on the ICL team to respond to that as well, and maybe ask you, Sarang, for some reflections on that.
Yeah, I mean, the negative number for India was kind of concerning for me. There's already budget constraints in India on all expenditure, and the moment you see a negative number such as this, it can be used to say, hey, you know, we did the right thing by not putting too much money in preparedness. But I think Nipah is one virus which has had, you know, some activity, but dengue, for example. And there have been discussions in India that once you have a strong surveillance system for COVID, maybe that can be used for other pathogens. Coming from a management background, I take that with a grain of salt because there are management structures which are not easy to repurpose. Technology may be similar. And we saw this even in the case of testing, where the HIV and TB programs had capacity for molecular diagnostics, but it wasn't overnight that you could repurpose it for COVID testing. So I think that friction needs to be considered. I think the fatality profile may be different for dengue, and so it is possible that the ROI may be different.
I think that really speaks to really looking at what the pandemic risk is in particular countries, in particular parts of the world, because it's similar with the other event that we did with the Africa risk capacity people, that, you know, the potential for Marburg to be hugely disruptive to economies, et cetera, was enormous, but it's not like there's going to be spread of Marburg elsewhere yet. Some of this, as you said, maybe prospectively, some of the same systems could work, because I would share your view that of course, there were investments that were made prior to COVID-19 that helped with some of the surveillance during COVID-19. I think the genome sequencing that the polio eradication efforts did, for example, was useful. But I don't think we can say that, you know, overall it was a great win, you know, that systems really adapted very well to trying to monitor respiratory pathogen in real time at the velocity that was needed. So would require substantial new investment to get up to speed to be able to respond quickly to these kinds of threats. Do you have any thoughts on that, Katrina or Patrick?
Yeah, I think, I mean, a key point is really to the preparedness plans, isn't it? To have a plan in place, who does what when an emergency starts, who collects what data, where are these data collated, how are the data streams going, to have all these data arrangements in place, because there was this big scramble of getting these systems in place as COVID struck, and that is really not necessary to do that once the emergency strikes. That is just being organized. And with respect, I think, to other pathogens, I mean, we're still worrying about Ebola and non-respiratory pathogen viruses, and the question of vaccines, right, and more sophisticated vaccine strategies. Do we do mass vaccination? Do we do ring vaccination? What is the comparative efficacy, cost effectiveness of this? I think is super important going forward, and certainly will keep us busy.
Well, I think that's the bottom line. We will all be busy, hopefully busy, because we hope to see more investment and interest in these topics going forward, and that we don't sort of repeat the cycle of panic and neglect going forward. Any last thoughts from the presenters today? Sort of the way forward? So we'll end with that, just to say thank you to all of you for this really heroic work. The Daedalus model is really a life's work, I think, for so many people on your team. And I really encourage people to take a look at your work. This is one product of that model, but it's not the only one. And so we welcome you, and also to recognize how great UK data is on COVID-19, how much it is in real time, and how jealous we all are of what Public Health England and others do to be able to feed some of these models in real time. With that, thanks to you and all the panelists, and we'll look forward to staying in touch on this.
Thank you. It was a pleasure.
Bye.